Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Outcome of Children with BCR-ABL1-like Acute Lymphoblastic Leukemia treated with risk-directed therapy based on the levels of minimal residual disease by Catherine Roberts et al. My name is Stephen Hunger, and I am Professor of Pediatrics and Chief of the Section of Hematology, Oncology, and Bone Marrow Transplantation at the University of Colorado School of Medicine and Children's Hospital Colorado in Aurora, Colorado, USA. I am a pediatric oncologist who specializes in treatment of pediatric leukemia, and I am the chairman of the Children's Oncology Group Acute Lymphoblastic Leukemia Committee. I have collaborated with many of the authors of this report, but was not involved in the current study in any way. Roberts describes the outcome of children with BCR-ABL1-like acute lymphoblastic leukemia, which I will call PH-like ALL. This subtype was first identified by two groups in 2009 and is characterized by a gene expression profile similar to that of BCR-ABL1 positive, or Philadelphia chromosome positive, ALL, but without presence of the 922 translocation known as the Philadelphia chromosome that causes BCR-ABL1 fusion. There is no unifying underlying molecular aberration present in PH-like ALL. It is both interesting and frustrating to the leukemia community that PH-like ALL can only be identified by a gene expression profile, and that the algorithms used by different groups to identify this entity differ significantly from one another. Thus, a case that one group calls PH-like ALL is not necessarily called PH-like ALL by a different group, and vice versa. However, thus far studies of PH-like ALL have all found several common features, including, in particular, a high frequency of deletions or mutations of the IKZF1 gene that encodes the lymphoid master regulator Ikaros, and a very poor treatment outcome with conventional therapy. This group and others have begun to unravel the underlying molecular lesions present in PH-like ALL. Most studies have found that about half of PH-like ALL cases have genomic rearrangements that lead to cell surface overexpression of the cytokine receptor CRLF2, with about half of these CRLF2 rearranged cases having mutations in one of the JAK kinase genes, most commonly JAK2. Many of the cases lacking CRLF2 alterations have genomic rearrangements that target one of a variety of genes involved in cytokine and growth factor signaling. This leads to production of fusion genes that phenocopy BCR-ABL1, meaning that they drive growth factor signaling in vitro and enable cytokine-dependent cell lines to grow autonomously in the absence of cytokines. One of the most common of these genes is ABL1 itself, so that there are a variety of fusion proteins that look like and act like BCR-ABL1, most importantly act like BCR-ABL1 in terms of response to the tyrosine kinase inhibitors imatinib and dasatinib. Three other structurally related genes are rearranged in PH-like ALL: the ABL1 relative ABL2, the platelet-derived growth factor receptor beta, and the CSF1 receptor, producing fusion proteins that cause growth factor independence and respond to imatinib and dasatinib in the same way as do BCR-ABL1 in Ph-positive ALL and variant ABL1 fusions in PH-like ALL. A second class of PH-like gene fusions targets JAK2, and these are highly responsive to the JAK2 inhibitor ruxolitinib in vitro. Thus, there is tremendous interest in detecting cases of PH-like ALL, identifying the sentinel genetic lesions that drive this phenotype, and assigning patients with specific abnormalities to treatment with chemotherapy plus the appropriate tyrosine kinase inhibitor. This makes PH-like ALL a potential poster child for precision medicine. So what about the new current study is new and different? Should these results change our understanding of PH-like ALL or alter our treatment approach? Roberts and colleagues analyzed children with ALL enrolled in the St. Jude Total 15 trial to determine which ones had PH-like ALL, what underlying genomic lesions were present in these patients, and how PH-like ALL patients fared with therapy. Some of the answers are surprising. About 12% of the St. Jude patients had PH-like ALL. Their presenting clinical features did not differ dramatically from the other cases, except for a higher incidence of male sex and Down syndrome, both of which have been reported consistently before. Unlike some other studies, there was not a higher frequency of high white blood cell counts at initial diagnosis in the PH-like cases. They weren't older than other cases, and most notably, they had an excellent outcome that was no different from the outcome of ALL patients without the PH-like gene expression profile. How do we explain these findings, and what do they mean? First, the St. Jude Total 15 study recommended stem cell transplant in first remission for patients with a poor early response, as defined by minimal residual disease, or MRD, levels greater than or equal to 1% at the end of the 6-week induction phase. The patients with PH-like ALL had a significantly worse MRD response than other patients, and 15% of PH-like ALL patients underwent hematopoietic stem cell transplant in first remission, as compared to only 4.3% of non-PH-like patients. And because of the poor MRD response, significantly more patients with PH-like ALL fell into the standard and high-risk groups and therefore received intensified chemotherapy. Thus, this study finds that patients with PH-like ALL fared as well as those without PH-like ALL, but it took more intensive treatment, including about 1 in every 6 or 7 patients undergoing stem cell transplantation in first remission, to achieve this outcome. A second major issue is that the study population here appears to be very different in important ways than the patients included in some of the other PH-like ALL studies, particularly those that my colleagues and I have done in the Children's Oncology Group, or COG. The incidence of PH-like ALL increases with age, and the age limit for the St. Jude study was 18 years, while the COG studies included older adolescents and young adults who are known to fare worse than younger children. Another difference is the patient ethnicity. The COG studies have a much higher frequency of persons of Hispanic ethnicity, another adverse risk factor, than present in Total 15. Surprisingly, only a small percentage of the Total 15 PH-like ALL patients had a significantly elevated white blood cell count. Only 4 of 40 were greater than 100,000, and one other was above 50,000. In the COG studies, there is a much higher frequency of patients with a very high white blood cell count. Another unique finding of this study was the relatively low frequency of Ikaros genetic lesions in the PH-like patients. This was only present in about a quarter of PH-like patients in the St. Jude's cohort, as compared to 60 or 70% or more in other cohorts. Thus, the St. Jude PH-like population differs significantly from other populations reported to date, with much lower frequency of patients with high initial white blood cell count and Ikaros lesions, which are uniformly associated with inferior outcome. Some of this is because this St. Jude study was an unbiased analysis of consecutively treated ALL patients, unlike the COG studies that have analyzed PH-like status in patients with other high-risk features. However, patient selection cannot completely explain the difference, as the European studies, which also found PH-like ALL patients to have a poor outcome, were also unselected and also had a much higher rate of Ikaros mutations and deletions than present in this cohort. Some of these differences may be due to random chance, as the number of PH-like patients identified in any single study is relatively small. This study had only 40 PH-like patients, only about 2/3 of which were fully characterized genomically. In conclusion, this study provides new insight into PH-like ALL, showing that poor early responses are much more common in these patients than others, but they can be overcome by intensified therapy that often included stem cell transplantation. More work is needed to understand the differences between this St. Jude report and those from other groups, and these results should in no way dampen enthusiasm to understand the genetic heterogeneity of PH-like ALL and test addition of tyrosine kinase inhibitors to chemotherapy when appropriate. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.